I'm Tammy Frank with the Nebraska Medical Association. I'd like to welcome you all to the first in a series of the Foster Healthy Weight and Youth webinars that will focus on the comorbidities of childhood obesity. First, I'd like to thank Dr. Carla Lester with Teach a Kid to Fish and the NMA's Childhood Obesity Prevention Project, Holly Damon with the Department of Health and Human Services Nutrition and Activity for Health Program, Dr. Christina Fernandez with Creighton University Children's Physicians, Dr. Sally O'Neill and the Creighton University CME staff, and Dr. Sandra Hassing with the AI DuPont Hospital for Children for all the work they've done to make this webinar possible. I'd like to introduce Dr. Carla Lester, who will talk about the CME credits associated with this webinar, and will give the background for the Foster Healthy Weight and Youth model. Dr. Lester is a pediatrician here in Lincoln that started a nonprofit organization called Teach a Kid to Fish. Its mission is to prevent and reduce childhood obesity by empowering Lincoln children and families to eat healthy and be active. Dr. Lester also developed the NMA's Childhood Obesity Prevention Project. Dr. Lester.
Thank you, Tammy, and we of course always want to thank Tammy Frank of the NMA for all of her hard work in developing this webinar series as well. So welcome to the Foster Healthy Weight and Youth webinar series. We're excited to launch the webinar series today, and especially very excited about today's speaker, Dr. Sandra Hassing, who is a leading national expert on medical intervention for the obese child and a true voice and advocate for all children. The Creighton University School of Medicine designates this live and enduring material activity for a maximum of 1 AMA Category 1 credit. The information in this training has been approved for a continuing education contact credit hour by the American Medical Association, the Nurses Association, as well as the Commission on Dietetic Registration. Participants should claim credit based on the extent of their participation in the activity. A detailed information sheet containing this information accompanied this webinar registration and may be found on the Creighton website. The Creighton University School of Medicine is accredited by the Accreditation Council for Continuing Medical Education to provide medical education for physicians. After the webinar, you will be sent links to the post-test as well as an evaluation via email. And you may also visit Creighton's website at cme.creighton.edu for more information. This activity has been planned and implemented in accordance with the essential areas and policies of the Accreditation Council for Continuing Medical Education through the joint sponsorship of Creighton University School of Medicine, Nebraska Medical Association, Teach a Kid to Fish, and Nebraska Department of Health and Human Services. Neither the planning committee or speakers for the webinar series have any conflicts of interest or disclosures and have signed statements claiming as such. Foster Healthy Weight and Youth is Nebraska's clinical childhood obesity model. Over the past few months, the clinical resources have been disseminated to physicians across the state. It is a comprehensive model with a toolkit, pocket reference algorithm, free CME training video, which outlines the steps in assessment, prevention, and treatment in the primary care setting, as well as providing resources for physicians on community outreach and statewide policy advocacy. There are also consistent messaging patient brochures and posters to resource your office. All of the resources are free and are available through the NMA's Childhood Obesity Prevention Project website, as well as through contacting Holly Dingman of the Nebraska Department of Health and Human Services. This was a collaborative project developed by multiple partners. And as an outcome of the Foster Healthy Weight and Youth clinical resources, we have developed the webinar series, and the objectives of the Foster Healthy Weight and Youth webinar series are to explain and illustrate childhood obesity comorbidities, describe and illustrate assessment of comorbidities in the primary care setting, and also to describe and illustrate treatment of comorbidities in the primary care setting. Today's webinar is titled Associated Comorbidities of Childhood Obesity. Our speaker is Dr. Sandra Hassing. She is the director of the Nemours Pediatric Obesity Initiative at DuPont Hospital for Children in Wilmington, Delaware. Dr. Hassing is also the chair of the American Academy of Pediatrics Obesity Leadership Work Group and serves on the American Academy of Pediatrics Board of Directors. Dr. Hassing, we welcome you to Nebraska via the wonders of technology, and with that, I will turn it over to you. Thank you.
Well, good afternoon, everyone. Excuse me. I think today I've included a lot of slides in the webinar basically to give you background. It's always hard to ask yourself the question, what comorbidities should you leave out? So with that said, this will be an overview of the comorbidities and help ground you in some of your thinking as to how you approach the children. Now, let me just make sure I can advance my slides. Tammy, did you turn it over to me? Okay, here we go.
Okay.
So about 5 or 6 years ago, I never would have had this slide on in the presentation, but I think it's worth noting that there are now severe obesity-related emergencies. And we're going to spend some time briefly just discussing these because I think it is within the spectrum of primary care to be aware that these do occur. The first new condition to appreciate is hyperosmolar hyperglycemic state. And this really, we will look at later how these children present, but it can be the first presentation of type 2 diabetes along with diabetic ketoacidosis. And this occurs in a state of relative decreased insulin action and leads to hyperglycemia and dehydration with a significant osmotic diuresis. The first reported cases of these in children were in 2004, and the article was entitled Death Caused by Hyperglycemic Hyperosmolar State at the Onset of Type 2 Diabetes. And this was a retrospective chart review where these children were considered to have this condition as their cause of death. All had, and I think this is a significant statement, previously unrecognized type 2 diabetes. And the conclusion of the authors of this paper were death may have been prevented with earlier diagnosis and treatment. This brings us to mind that when we have obese adolescents and children, that they may present to medical care with nonspecific symptoms, which may be the first signs that they are developing type 2 diabetes in a fulminant state, whether DKA or hyperglycemic hyperosmolar state. So in this particular paper, children presented within 2 weeks of their demise with nonspecific symptoms: vomiting, abdominal pain, dizziness, weakness, polyuria, polydipsia, weight loss, and diarrhea. And I think it just reminds us to be ready to check blood sugars and maybe even hemoglobin A1Cs in our offices when we have sick children predisposed to diabetes. The diagnostic criteria for hyperglycemic hyperosmolar state are listed here. You can see it's extremely elevated blood sugars and osmolalities, moderate serum bicarb greater than 15, ketonuria, and stupor or coma. And I think it just is a call to be aware that a sick, obese child, we have to maybe look a little deeper than just standard pediatric diagnoses to make sure they're not on a trajectory for DKA or HHS. Pulmonary embolism certainly can present in the obese adolescent or child with the classic symptoms of dyspnea, chest pain, decreased O2 requirement, and hemoptysis, with the other signs and symptoms. Obstructive sleep apnea and coagulation disorders increase the risk for pulmonary embolus, and this is the most common complication of gastric bypass or banding in adults, and has been reported in adolescents after surgery and in adolescents post-op and with coag disorders. I'm having trouble with the slide. Let's see. Excuse me a minute. The slide is not advancing. Tammy, could you advance that? Thank you. Cardiac disease, we think of classically in obesity as hyperlipidemia, hypertension, arteriosclerotic disease, but there is an entity known as cardiomyopathy of obesity, which really is a reflection of cardiac steatosis with left ventricular dysfunction, dilatation, and hypertrophy. You can also get right ventricular dysfunction exacerbated by pulmonary hypertension due to upper airway obstruction. And this is a X-ray of a young man who walked into our clinic, dyspneic, who was in heart failure from cardiomyopathy of obesity. This occurs often at the extremes of obesity, but again, needs to be considered as a diagnosis and to rule this out. I'm not going to spend a lot of time on these complications of surgery, only to say that adolescents are getting both bypass and banding surgery. They're presenting in emergency rooms with complications or maybe calling you with complications. They may be getting surgery at remote locations and coming back to the primary care clinic with these complaints. So I think it's just these slides are here for your reference, but you can see that there are early complications which really are proximal to surgery. There's late complications which involve, among other things, reflux, hernias, malnutrition, pancreatitis, and this is from Roux-en-Y gastric bypass. And all of these have been seen in both adolescents and adults. Lap band, you can also have adverse events, although fewer, but you can have early postoperative hemorrhage and infection and perforation and late complications. The erosive and slippage complications are somewhat less now because of the new surgical procedures about suturing in the band. Just a point, post-bariatric surgery medication, that should be medication considerations. Because of the small size of the pouch of the stomach, no aspirin or aspirin-containing products, no nonsteroidal anti-inflammatory agents, and all medication should be crushed to aid absorption, no extended release or enteric-coated products. There are metabolic complications of bariatric surgery, which include anemia. You can see that here, gallstone formation, calcium and vitamin D deficiencies, and protein deficiencies, and these usually occur in the context of patients not adequately addressing their follow-up. So hopefully you will not see these emergencies, but we have. They do occur, and it just is good to be aware of them. We next move to the comorbidities that you may encounter that require immediate attention. And you're aware that pseudotumor cerebri presenting with papilledema occurs in the setting of obesity, and the definition here is raised intracranial pressure with normal CS cerebral spinal fluid in the absence of ventricular enlargement. This is a diagnosis of exclusion when you've ruled out other causes of papilledema. It occurs largely in obese children, and obesity and recent weight gain were the only factors found more often in the pseudotumor patients than controls. It may present with headaches, vomiting, blurred vision, or diplopia, rarely with neck or shoulder or back pain. The last, one of the most recent cases we had was an adolescent male who presented to the emergency room with a leg injury. An astute resident picked up papilledema. It turned out he was already having visual field cuts and headaches, which he had not been complaining about to anybody. So you really need to look at the fundi of your patients. The end stage of this is blindness, so this needs to be treated aggressively. Diamox is the first-line treatment. In severe cases, a lumboperitoneal shunt needs to be placed, and weight loss is the treatment, ongoing treatment. Associated with pseudotumor are these other conditions, just for your reference, to know that you can have a series of other or associated conditions that can make pseudotumor more likely. So points to remember are a fundoscopic exam should be a routine exam, part of the exam of your obese child. Kids may not complain of visual field disturbances, so you need to test, and pseudotumor is essentially a diagnosis of exclusion. Subcapital femoral epiphysis is a not unusual complication of obesity, and you really need to suspect and immediately evaluate this in an obese patient who presents with a limp. Over half to 3/4 of the patients with SCFE are obese. You also need to remember that this can present with complaints of groin, thigh, or knee pain. This is because the obturator nerve from the hip passes lateral to the alongside the knee. So even knee pain, you need to be suspicious for a possible SCFE. You can see on this X-ray on the patient's left hip, he limped into clinic and was operated on that afternoon after this diagnosis was made. The motion of the hip in abduction and internal rotation is limited. You need to get AP frog leg views of the pelvis that includes both hips, and that's because bilateral disease occurs in up to 20% of patients. This requires immediate surgical correction. There are now pre-slips or widening of the growth plate identified on children as young as 9. So age should not be a factor in withholding your suspicion. If they're limping and have lower extremity complaints, you should be suspicious and you should move on through your evaluation. This really occurs because you're really fracturing through the growth plate in the zone of hypertrophic cartilage cells, and these cells are under the influence of both gonadotropin, gonadotropin hormones and growth hormone, and are susceptible to fracture. How to predict this, though, is largely unknown. Not obviously all obese children get SCFE. It's been impossible to date to really predict who this is going to affect, so you have to be suspicious of any lower extremity complaints. Associated causes are listed here and have to be elicited in the history. And this is just the result of that young man's pinning to realign his hip. And as you well know, pinning a hip has some long-term consequences for these children, and to identify these before they completely fracture through is a good, would be worthwhile, and we have to be alert. Blount's disease is another particularly pediatric complication of obesity, and you can see 2/3 of patients with Blount's may be obese. This is just the erosion of the tibial plateau that you see in Blount's disease, and it's injury to the growth plate and requires evaluation and correction by an orthopedic surgeon and weight loss. There are cases that are reported untreated. You can actually get peripheral neuropathies if the bowing is severe enough. This is the external brace, post-op bracing of a Blount's disease patient. Points to remember: careful hip and knee exams should be a routine part of the evaluation of every obese child. If they complain of hip, knee, groin, or thigh pain, they should have a complete and thorough examination and radiologic studies. You really, with an obese child, an unusual or abnormal gait should not be attributed to excess weight, but should be evaluated. As you all are quite aware, upper airway obstruction sleep apnea syndrome is common in the obese population. The adipose tissue in the upper airway contributes to this. Abdominal adiposity may also compromise respiratory excursion, and adipocytes, as they do in the liver and in muscle, infiltrate into diaphragmatic muscles and may alter respiratory mechanics. So there are a lot of respiratory effects of obesity. Obstructive sleep apnea syndrome in children is defined as a disorder of breathing during sleep characterized by prolonged partial upper airway obstruction and or intermittent complete obstruction that disrupts normal ventilation during sleep. There's a dynamic relationship with the hypopharynx during breathing. This depends on the pressure that's generated, airway size and shape, and airway tone. And these are just MRIs of inspiration and expiration, and courtesy of Dr. Aaron Chittickle in our pulmonary department. The effects of obstructive sleep apnea are along a spectrum. So you have cognitive effects of decreases in learning and memory, attention, motor efficiency, graphomotor ability. This can sometimes look kind of similar to the effects of attention deficit disorder. You have pulmonary hypertension, systemic hypertension, and right heart failure as the cardiopulmonary effects, and sleep disturbance is quite common in the obese population. And 40% of severely obese children in one study demonstrated central hypoventilation and along with their upper airway obstruction. I find it helpful when I'm looking at the symptoms to look at nighttime symptoms and daytime symptoms. So nighttime symptoms would be snoring, restless sleeping, heavy breathing, orthopnea, night awakenings, enuresis, observed apnea, diaphoresis, or cyanosis. Daytime symptoms would be morning headaches, daytime tiredness, napping, poor functioning in school, inattentiveness, short-term memory deficit, irritability, and elevated blood pressure. But the gold standard of this diagnosis still remains nighttime polysomnography. Symptom checklists are used in research settings, and audio and videotaping may also be used, but there's not a high correlation between positives on a checklist or audio taping to obstructive sleep apnea by polysomnography, so you really need to order that sleep study when you suspect sleep apnea. The definitive treatment for this is weight loss. You can do a TNA, and that would be a temporizing procedure. You can prescribe CPAP and BiPAP and titrate that in the sleep lab. Unresponsive cases, there's uvulopharyngoplasty, craniofacial surgery, tracheostomy, and in adults, gastric bypass and banding have been used as a treatment. So you want to ask specifically about sleep disturbances, snoring, and sleep positions. If you ask how the child sleeps, you may find that sleeping sitting up. Families might not volunteer this because it's become normative. That's just the way he sleeps. So you need to specifically ask. You need to consider obstructive sleep apnea syndrome in obese children with poor school performance and concentration difficulties. That's one of the diagnostic considerations. And sleep symptoms can evolve over time. So you can be following a child. Weight gain, intercurrent upper respiratory infection, tonsillar enlargement can provoke symptoms, and they can show up over time. There is a co-occurrence of asthma and obesity, and asthma prevalence, as is obesity prevalence, is at an all-time high. If you look at asthma and obesity, asthma is a classic example of an obstructive lung disorder. Obesity, there is a restrictive component here with chest wall restriction due to body mass, abdominal fat, poor ventilation, and lung compression. And tissue deposition of fat in obesity can cause airway narrowing and fixed airflow obstruction. So they are different but can present with shortness of breath during exercise and what looks like a reactive airway component. Pulmonary mechanics change with obesity. There's decreased lung volumes and thoracic distensibility, and obese children have a higher frequency, lower tidal volume pattern of breathing. Now, that said, that asthma, the respiratory effects of asthma and obesity are different. Obesity may contribute to the severity of asthma. Obese asthmatic children have more missed school days, receive more medication, have lower peak expiratory flow rates than non-obese asthmatic children, and they report increased cough, wheeze, and dyspnea. And bronchial hyperresponsiveness is felt to increase in obesity. Weight reduction in obese patients reduces asthma symptoms, and leptin is increased in obese children and in normal weight asthmatic boys versus non-asthmatic boys, so there may be some inflammatory component induced by obesity contributing here. So although they are different, they both co-occur and can make each other worse. Obese children, if they're inactive, may not be reporting symptoms of co-occurring asthma. So you want to specifically ask if their activity patterns have altered. Have they stopped playing sports? Have they stopped being active? Are they slowing down? Are they losing interest? This may be more than lack of motivation. It may be that they actually are having some shortness of breath with exercise. Likewise, as exercise increases during treatment of obesity, symptoms of exercise-induced asthma may emerge in a child who previously wasn't inactive and wasn't active and wasn't complaining. And it is important to optimize asthma treatment in every obese asthmatic child to optimize their exercise capabilities. If we move on to the liver, this is perhaps one of the biggest black boxes in obesity management. It is not unusual in obesity for most people to have deposits of fat in their liver and steatosis. However, about 15 to 20% of people who have fatty liver from obesity go on to develop inflammation, fibrosis, and some of these people go on to develop cirrhosis. This is felt to be possibly a second hit where you have a predisposed fatty liver with another environmental or genetic hit that starts the inflammatory fibrotic cycle. This is a liver biopsy of a 10-year-old girl where you can see fat deposits in the hepatocytes, as well as bridging inflammation around the portal triads and already bridging fibrosis. This is diagnosed with increased liver enzymes and fatty liver on ultrasound in the absence of other causes of liver disease. The definitive diagnosis is made with liver biopsy. Each gastroenterologist will have their own criteria for when they want to biopsy these children. As I said, about 20% of obese children have evidence of steatohepatitis, which is the elevated liver enzymes and inflammation. Obesity and type 2 diabetes are the strongest predictors of progression of fibrosis. And age is also a risk factor for cirrhosis. This may really reflect a longer time of having an at-risk fatty liver and inflammation to develop fibrosis. Predictors of elevated liver enzymes in obese children are male children, Hispanic ethnicity, and elevated BMI. Predictors of fibrosis or obesity, insulin resistance, and maybe leptin. A liver with a fatty liver runs a higher risk of being damaged by other liver toxic compounds, from viruses to endotoxins. So what the impact of this is largely unknown, but if you have a child with a fatty liver, they potentially are more at risk for other liver risk factors. If they lose 10% of their excess weight, their liver enzymes will normalize. You can decrease the fatty infiltration. It's not sure if you have fibrosis, if all the fibrosis will go away. In adults, about half the adults who have fatty liver with fibrosis and lose weight, about half of them still have some fibrosis after the weight loss. There's a current trial, and I don't think it's been reported out yet, looking at metformin as a treatment for fatty liver and NASH. Gallbladder disease, you see it's pretty classic when you see it, just as it is in any patient, although there's a higher incidence in with children with obesity. Rapid weight loss in adults can precipitate gallbladder disease. And adolescents, the relative risk of gallstones in adolescent girls with obesity is 4.2, and hormonal contraceptions increase that risk. Just added factors to note, and treatment is as it is in adults. If we look further along the chronic obesity-related comorbid conditions, we see that these cluster around insulin resistance, impaired glucose tolerance, type 2 diabetes, polycystic ovarian syndrome, hypertension, and hyperlipidemia, all the metabolic consequences of obesity. There are also clearly psychological comorbid conditions, which we'll talk about. Acanthosis nigricans is seen frequently in all populations, is associated with insulin resistance. It's really a hyperpigmentation on the rapidly growing cells in the skin. You can see this in the neck, axilla, groin. It can occur over the knuckles, and is in other insulin resistance syndromes and in some malignancies. Obese patients with acanthosis tend to run higher fasting insulins and have lower insulin sensitivity. It's not across the board. This is something, though, that parents really respond to when you point out acanthosis. They can see it. You can see it go away as the lifestyle normalizes, as the weight is lost. It's something the parents can follow. I usually say it's indicative of increased risk. The parents and then we can get into a description of what insulin resistance, prediabetes, or diabetes means. These slides are courtesy of Dr. Janet Silverstein and really show progression from normal glycemia to type 2 diabetes. This is our big fear, that obesity is pushing impaired glucose tolerance and the diabetes. And in adults, you can see the type 2 epidemic following exactly on the heels of the obesity epidemic. And you can see the cutoff points for fasting glucose in both impaired fasting glucose and diabetes. This is a study of over 100 obese children and adolescents, trying to look at what the progression looks like from prediabetes to diabetes. In 8 children with impaired glucose tolerance, in children with impaired glucose tolerance, 8 of these 117 children developed type 2 diabetes within 2 years. 15 reverted to normal glycemia, 10 remained impaired glucose tolerant. The predictors of progression are severe obesity and persistent weight gain, which is no surprise, a family history of type 2, and increased insulin resistance. Insulin resistance normally increases during puberty. It's increased in the African American population, inactivity, visceral fat distribution, and polycystic ovarian syndrome. But you can see that even these patients, a quarter of these patients progressing to diabetes in 2 years is a very rapid rate of progression. And so we have a small window of opportunity here from prediabetes to type 2 to really have an impact on these patients and try to reverse the effect. And you can also see in that previous slide that you can reverse this and you can get back to normal glycemia. And so I view this as a tremendous window of opportunity to have effect with these patients. And this just gives you an appreciation of the incidence of type 2 diabetes in our differing ethnic groups. And Native Americans and particularly the Pima Indians are particularly predisposed, along with Asian Pacific Islanders, followed by African American population, Hispanic, and non-Hispanic white. The diagnosis of diabetes can now be made using a hemoglobin A1C, and I think this is where it gives us a big advantages in our offices because you can, if you buy the piece of equipment, you can perform this in your office. You need a repeat test over 6.5 to make the diagnosis, but it can be made. You can also use a random glucose over 200 plus symptoms of diabetes, a fasting blood glucose over 126, or a 2-hour plasma glucose over 200 after an oral glucose tolerance test to make the diagnosis. Clearly, if you see associated findings of polycystic ovarian syndrome, acanthosis, dyslipidemia, and hypertension, you already have the metabolic impact and need to be checking for diabetes and impaired glucose tolerance in these patients. We do see kids who walk into our clinic with diabetes previously undiagnosed when we check their hemoglobin A1Cs. This is just goals of treatment of type 2 for your reference. It just looks at the holistic approach. When you have a type 2 patient that goes from ensuring psychological well-being to control of the morbidities of hypertension and hyperlipidemia which are associated, and to engage the patient in self-monitoring, to name a few of the goals. Metformin is the first-line drug when you have a type 2 patient. It can be used in patients with diabetes, clearly, but in patients with both impaired fasting glucose and impaired glucose tolerance, plus one of the following: family history, obesity, A1C over 6, comorbidities of dyslipidemia or hypertension. Metformin is approved in children only over 10. And the mechanism of action is it decreases hepatic gluconeogenesis and increases insulin sensitivity. Side effects can include nausea, vomiting, fullness, constipation, and heartburn, and there are reports in the literature of lactic acidosis, which is something to be aware of. If metformin is contraindicated for any of the reasons you see on the slide, then insulin needs to be used. If metabolic control cannot be achieved with lifestyle and metformin, then the patients move to insulin, and if beta cell failure occurs. And the beta cell failure will occur in diabetes from the toxicity of hyperglycemia in adults often 6 to 8 years after diagnosis. At this point, you should be invoking your endocrine colleagues to help you with the diagnosis and treatment, but it's good to know where these patients are headed as the diabetes progresses. Polycystic ovarian syndrome really is quite common in the adolescent female population with obesity. You diagnose it with hyperandrogenism, oligomenorrhea or amenorrhea, hirsutism, acne. This results in polycystic ovaries and eventual infertility if untreated. The girls that we see with premature adrenarche turn out to be at increased risk for polycystic ovarian syndrome, and so they need to be followed if they have premature adrenarche for PCOS. Hypertension is a common co-occurring comorbidity, and you need to pull out those blood pressure tables to use because you have to look at the height. And now in the fourth report really recommended that we stage these patients into prehypertension, stage 1 and stage 2 hypertension, as you see on this slide. The goal for all patients would be a blood pressure under the 90th percentile for age and gender. Just want to make a comment about measuring blood pressure in obese children. You really need to use the right size cuff. We have dispensed with electronic blood pressure monitoring. We take blood pressures manually. We were getting a lot of elevated pressures with the electronic cuff, just I think on how that is used. and we check at every visit, all the follow-up visits. Hypertension, you would recheck in 6 months, or we check ongoing when we see our patients monthly. Engage in weight management counseling. Pharmacologic therapy here is not indicated unless you have secondary disease or end-organ disease. Stage 1 is recheck in 1 to 2 weeks, evaluate and refer if the blood pressure continues to be elevated. Weight management is the first line, and pharmacologic therapy if they're symptomatic. If the hypertension is secondary, they have end-organ damage, diabetes, or persistent hypertension despite your best efforts. Stage 2 is an immediate evaluation and pharmacologic therapy, and you can see the repertoire of drugs that might be used on this list. Hyperlipidemia as well is a very common complication of obesity, and the pattern of hyperlipidemia is elevated LDL cholesterol, elevated triglycerides, low HDL, and this is really the one component of the metabolic syndrome. The etiology of this is really from the increased central fat distribution, and hyperinsulinemia produces this pattern of hyperlipidemia. This is a table just categorizing low, normal, and high levels of lipids for your reference, and many parents are very responsive when they get abnormal lipid patterns back for making dietary change. The risk of hyperlipidemia in overweight adolescents, there's a 2.5 almost times increase in the prevalence of high cholesterols, 3 times prevalence of elevated LDLs, and an 8-fold increase in low HDLs. Overweight adolescents, untreated, tend to maintain these values through adulthood. So it's wise, if you identify it, you can always intervene. Even if you're not at pharmacologic levels to intervene, you can always intervene with lifestyle change. Elevated BMI is associated with escalating cardiovascular risk. So a BMI over 95th percentile in the study that David Friedman did showed that 39% had 2 cardiovascular risk factors already, and 65% went on to have an elevated adult BMI. If your BMI got over the 99th percentile, almost 60% had 2 cardiovascular risk factors, and 88% had an elevated adult BMI over 35. And 4% of U.S. children had a BMI over the 99th percentile. So we do have a whole cohort of children that have severe obesity, and there's some indication that while the levels of obesity may be plateauing in this country, the levels of severe or morbid obesity are escalating. So this is a particular high-risk group for us. The treatment of lipid disorders and obesity is nutritional, lower fat and cholesterol intake, lower total calories, increased fiber, and pharmacologic therapy if dietary therapy has failed or is ineffective after 6 months. Remember, for children over 10, and these would be your LDL indicators, LDL cholesterol over 190 or LDL over 160 with 2 major risk factors. Cholestyramine is approved for use in children. Absorption, because it acts to absorb cholesterol, absorption of other medications is affected. These are the worsening of bleeding problems, constipation, gallstones, hemorrhoids, ulcers, hypothyroidism, and renal disease and PKU can occur. There's some bloating and gastrointestinal side effects, and it's contraindicated if you have markedly elevated triglycerides. Studies of statins for hypercholesterolemia have been studied up to 48 weeks in children, not long-term. These are not approved in pregnancy. So again, at this point, I think cardiology consult would be good to see what your local cardiologists are doing with this class of drugs. Hypertriglyceridemia, decreased simple sugars, weight loss. Evaluate for the comorbid conditions that can be associated with hypertriglyceridemia, and fish oil 2 grams a day can be used if the triglycerides are over 500 to 700. And at that point, there is a small risk of bleeding, so you may want to restrict contact sports. If we move into the psychological morbidity, we're all very well aware that there's both a higher incidence of psychiatric disorders in the obese population a priori, and obesity also results in psychological morbidity. The most common of these are depression, anxiety, low self-esteem, the effects of teasing and bullying, and binge eating disorder. Additional conditions which may impact treatment, in other words, if the children have these conditions, treatment will be more, you will have to tailor treatment around these, which would be ADHD or ADD, bipolar illness adjustment disorder, or oppositional defiant disorder. Our treatment present challenges to implement treatment. If we look at depression and obesity in a study of adolescents in grades 7 to 12, depressed mood actually predicted follow-up obesity. So children that were depressed at these ages when followed became obese. And so I think it's worth noting that many children turn to food and and change their active lifestyles when they're depressed, and this can put them at risk for obesity. In a study of chronically obese children, and this was from Appalachia, they had significantly higher rates of oppositional defiant disorder, and in boys, higher rates of depression. And there were no difference among groups in a lot of demographic parameters such as gender, family structure, parenting style, family history of mental illness, drug abuse, or traumatic events. Chronic and childhood obesity were associated with having a low family income and low parent education in this population. Health-related quality of life is low in obese children, and they rate themselves as having low quality of life along all domains. The parents rate the children as having even lower quality of life, and these are comparable with children who have cancer. If you have obstructive sleep apnea syndrome, your quality of life decreases even more, and and really affects physical functioning in a very significant way. To just round up on this quick tour through the comorbidities, all obese children deserve a complete evaluation that includes history, review of systems, and physical, focusing on holistically, but also on their obesity-related comorbidities. The treatment of obesity reduces morbidity, and even small weight loss can have a significant impact on the comorbidities. And children who have complaints and have issues like poor school performance and are functioning poorly really deserve a global assessment around these obesity, and nothing really should be attributed to weight itself in the sense that, they're not paying attention, they're just obese. We need to really look carefully at the whys and wherefores. So I'll leave you with that and be glad to take any questions.
Thank you, Dr. Hassink and Dr. Lester. We'll now open up the webinar to any questions you might have. Again, if you have questions, you can either type them into the questions section there and we'll read them off, or you should see a little button that looks like a hand that says raise your hand. You can do that and we will unmute your line so we can all hear you. So we'll give a couple minutes here to let people compile questions if they like to do that.
Dr. Hassink, this is Dr. Lester. One of the things that we noticed, we recently had performed a survey from physicians across the state, and we asked them things like, are you charting BMI percentile, are you assessing nutrition, physical activity, sedentary time, behaviors, are you setting goals, those kinds of things. And we found that of those surveyed, that 41% are doing charting BMI percentile always, and about that many are usually doing that. So there's this great disparity among what's happening in the primary care setting, and I understand fully the barriers that exist there as far as time, lack of resources, healthcare policies, and things like that. But yet these kids are so sick, as you have really demonstrated today, and there seems to be such a great disparity or chasm between what's happening currently in the primary care setting as opposed to the level of sickness of these children. And so how can we, or do you know, this is kind of a loaded question, but what's happening as far as healthcare policy, or I know that you've done talks and lead the work group with the AAP, and what's happening for healthcare policy so that we're improving reimbursement, evidence is being gathered for treatment strategies, those sorts of things.
So I think I appreciate that the work of obesity is, if you want, is new work for pediatricians. So this is on top of the work we're already doing. There's a couple things to look at here. We just finished a 4-year quality improvement initiative with our primary care practices in our area, where we actually met and worked through the workflow changes that might enhance this work of how to use your office team to help you assess BMI, do some nutrition counseling, change the office workflow so that it doesn't all fall on the physician. I think we have to be cognizant of how we get this work done, because we're called to do prevention on all children and early intervention and treatment on the affected children. And you know that the HEDIS measures now that insurance companies are required to report include measuring BMI, nutrition, and activity counseling. So I think this work needs to be incorporated into pediatric offices for its own sake and for the sake of identifying these children who often are medically fragile and vulnerable children that need to be evaluated. Now, with that said, there are national efforts to look at reimbursement strategies. The Alliance for a Healthier Generation has engaged a number of insurance companies into providing at least 4 pediatrician visits and 6 dietitian visits that are paid for in overweight or obese children. The comorbidities, in my experience, are always paid for. If you have a child with comorbidities, that does not represent a barrier to reimbursement. I think that what we have to do is, I think the reimbursement is out there and is coming. I think the real issue is the workflow in the office and how to adjust to accommodate up to maybe 30% of the kids who are obese, and in some high-risk communities, 50% of the kids who are obese. People are experimenting with group visits. In that area, I think payment mechanisms are lacking. We could talk if people have questions about how people are trying to do group visits. And clearly states and federal agencies are looking at global policy changes that will impact obesity prevention mainly. I think the treatment obviously is still falling on us to clearly identify these children and get them to treatment.
Thank you. We do have a question from Dr. Fernandez, who you know well.
Yeah.
And it says, do you draw leptin, vitamin D, insulin, and hemoglobin A1C on a regular basis?
Okay. Leptin, no. There's only a handful of children that have leptin deficiency been reported. And so the most common condition is leptin, high leptins, because of the leptin resistance and obesity. So when suspicious, I would draw it, but not. Vitamin D varies all over the place with obesity practitioners. Vitamin D has clearly been reported as a risk in obesity and for patients with diabetes. Frankly, in our population in the Northeast, almost every obese child that we draw vitamin D on is deficient. So I think you have to know your population and know what interventions you're going to make. We're still drawing it, but debating it. Christine, I forgot the other 2. Leptin, vitamin D, hemoglobin A1C. We do hemoglobin A1Cs from a finger stick on all our patients. We find it very useful as just a screening test. We also use it to track treatment. We like it because you can do it right in the office, and you know right away where you stand. So we do that on every patient. And I forgot the 4th one.
I think that's everything.
Was that it?
Insulin.
Insulin. We have, but we are not doing insulins anymore now that we have the hemoglobin A1C. We feel that's a better indicator of diabetes risk, although we are not and this is just our clinic, when we hit a hemoglobin A1C of 6, which is in the pre-diabetic range, we often find ourselves doing 2-hour glucose tolerance tests with insulin, so we get the fasting insulin there. So we have shifted a little bit away from the insulin as we've been looking at the hemoglobin A1C more.
Okay, great, thank you. We have another question from Jenica.
Yes, thank you. I was just wondering, when you're talking about with the A1Cs and doing those with every patient, obviously if you have a patient who's a pre-diabetic state, they're not necessarily going to have an elevated A1C, but wouldn't checking for the insulin level be more indicated so that you know if you needed to do the next step of doing an oral glucose tolerance test?
Well, we look at, let's see, 5.7 to 6.4 as indicative of, elevated of insulin, prediabetes.
Mm-hmm.
So when we're using 6 as our trigger to do a 2-hour, so that's just, we do not miss, we're not missing anybody by using 6 that we know of. Fasting insulin, there's a debate. I think a low fasting insulin helps you. So fasting insulin under 20 pretty much predicts that you're not going to have insulin resistance. But a high insulin and the level of that insulin doesn't always predict what you're going to see on a 2-hour. So for many years we looked at insulins. I think we're just looking at cost and trying to figure out what's going to trigger a higher level of intervention. I don't think it's wrong to use insulin. I think you just have to know what you're triggering with it. If you're going to, are you using insulin to trigger a 2-hour?
I just from the research and literature that I've gone over, being careful basically about using just the A1C because you do miss those people who might have greater fluctuations, who may have what seems to be a stable A1C, but you're missing those highs and lows that are occurring before you actually go into full diabetes.
Yeah, and so you would be using what insulin value? I'm just curious. What are you using to trigger your 2-hour in terms of your insulin level? Any abnormal insulin?
Well, yes. I've had patients with insulin levels as elevated as 32 who had a normal A1C and did an oral glucose tolerance test, and it showed impaired glucose state. And then I've had some who've had insulin levels with greater than 20 as that marker, and we still do the glucose tolerance test because of other indications such as nocturnal enuresis. To go ahead and do the 2-hour, just knowing that that A1C may not see all of those fluctuations.
And I would agree, and I think that you bring up a good point that we're always looking at the other markers of insulin resistance. So if you have, acanthosis, PCOS, family history of diabetes, impending puberty would all be reasons to do a 2-hour. So I think that low insulins, we haven't completely abandoned it. Low insulins, I think we can rule out. High insulins, I think you have to move on to your next step, and that I would agree with.
Thank you.
Any other questions or comments? We did have a comment from Dr. Tom Tonagis that said great presentation. So
Thanks,
thank
Tom.
you again, Dr. Hassing.
Okay.
We appreciate it so much.
Okay, take care, everyone.
Yeah, thank you. Just as a reminder, you will receive an email with links to the evaluation and the post-test to receive your continuing education credit. And you may also visit the cme.creighton.edu website for more information. And those are the links there as well that you can quickly write down. Just kidding. Again, if you'd like to become a champion in your community and within your practice and circle of connection, just log on to the NMA's Childhood Obesity Prevention Project website, and that will resource you with the information as well as the Foster Healthy Weight and Use resources. We appreciate you joining us for today's webinar, and hopefully you were provided with a lot of very helpful information, and look forward to our next webinar, which will be in March, where we continue to address the comorbidities in primary care practice. Again, the Foster Healthy Weight and Youth resources and the website, and thanks again.